everyone. Today I'm going to be talking to you about some bio-inspired solutions for premature birth in sort of a mixed chalk talk style. So first, what is preterm birth? Preterm birth is defined as delivery before 37 weeks of gestation. 15 million births are considered preterm annually, with over 1 million of those cases resulting in infant mortality. In fact, preterm birth is the leading cause of both infant mortality and morbidity. Those that do survive have greatly increased risk for severe disabilities such as hearing and vision impairments, cerebral palsy, asthma, and learning disabilities. Of the 1 in 10 babies affected, the probability of survival greatly depends on global location. Low-income settings increase the chance of mortality due to a lack of cost-effective care options. However, this is truly a global issue. The U.S. alone spends $26 billion annually on preterm birth care, and that does not include the cost for the associated morbidities. But in order to understand this, we need to familiarize ourselves with healthy pregnancy. Pregnancy normally proceeds with the fetus growing within a muscular organ called the uterus, which is connected to the vaginal canal by a small cylindrical thickening of tissue called the cervix. The fetus grows within two delicate membranes, the amnion and the chorion, and it is provided nutrients via the umbilical cord connected to the yolk sac and placenta. The fetus is shielded from the external environment by the two membranes, the cervix, and a small deposit of cervical mucus that plugs the canal opening to the vagina. The cervical mucus is essential for preventing microbial contamination of the womb, and it is highly affected by the vaginal microbiome. Over the course of pregnancy, the cervix softens, altering its mechanical properties from a strong, load-bearing structure that holds the fetus up to a flexible material that allows the baby to pass out of the vaginal canal. The reproductive tract microenvironment also shifts over time from an anti-inflammatory state to prevent infection to a pro-inflammatory state to induce uterine contraction. It is also essential for us to understand the influence of the vaginal microbiome. In a healthy individual, the vagina is characterized by very little diversity of microbial species due to lactobacillus colonization. Lactobacillus is a commensal species that is beneficial because of its production of lactic acid. The release of lactic acid maintains the vagina at a pH of 4.5, which is too harsh for most other microbial species, including those that would promote inflammation. Also, because this is the typical environment, the mucus plug chemistry is optimized for stability at low pH. But more than that, lactobacillus imparts protective functions in pregnancy by inhibiting genes associated with cervical remodeling, thereby retaining its load-bearing functionality. And it also promotes the production of anti-inflammatory cytokines. To create lactic acid, all it needs is a sugar or starch. Using glycolysis, it will convert that to pyruvic acid, and then through the enzyme lactate dehydrogenase, the protonated lactic acid molecule is released. With such complexity of natural materials and processes involved, there are many areas that can fail and lead to preterm birth. The causes can be broken down into 4 main categories. However, I am going to focus on the last 2 that comprise the majority of cases. 20 to 30% of preterm births are the result of premature rupture of membranes, otherwise known as PPROM. This is the breaking of the chorion or amnion sacs. 20 to 25% of cases are the result of inflammation and infection. This is intimately tied to cervical dysfunction and the microbiotic environment. Inflammation and infection are associated with cervical shortening and premature softening, and cervical shortening and premature softening are associated with ascending infections where microbial species can pass into the womb. The directionality in which this proceeds is pretty unclear as of now. Preterm birth is most often diagnosed mid-trimester, and there are some existing treatment options available, but many have limitations and none are holistic approaches to address the cervix, the membranes, and the infection all at once. For pharmacological approaches, antibiotics are used to control the microbial environment, but the reported efficacies vary greatly and recurrence of infection occurs often. Tocolytics are drugs used to slow uterine contractions, so they're really only useful closer to term. Progesterone is a hormone that naturally increases over the course of pregnancy and has been shown to have anti-inflammatory effects and reduce cervical insufficiency. We'll talk more about that in a bit. For mechanical options, the cervical circlage is the most common solution, which includes stitching the cervix such that the canal is constricted and the weight is more supported. However, this also has mixed efficacy, increases the risk of inflammation, further risking preterm birth, and is associated with many adverse effects. Lastly, the cervical pessary is a mechanical device that is used to constrict the cervix without surgical suture intervention. So let's look a bit closer at those two highlighted solutions. Progesterone is known as the pregnancy hormone, and it increases as pregnancy proceeds, but to impart its effects, it must bind to its receptor. There are two isoforms of the progesterone receptor, PRA and PRB. PRA has been shown to induce an anti-inflammatory pathway, whereas PRB induces a pro-inflammatory pathway. As a healthy pregnancy proceeds, the ratio of PRA to PRB decreases, such that the protective anti-inflammatory state that is needed during pregnancy shifts to the pro-inflammatory state that induces uterine contractions for labor. Thus, when implementing progesterone as a preterm birth solution, one must consider not just administering progesterone, but controlling the receptors available for the binding as well. The cervical pessary is a flexible elastomeric device that can be inserted by a physician to constrict the cervical canal and redistribute the weight of the fetus and uterus, but then is removed at term. The uterus and fetus generate an intrauterine pressure that has been mathematically modeled by this equation, where Y is the amniotic pressure that can be measured by a physician, and X is gestation time. The cervical pessary serves to support the accelerated increase in pressure that is experienced in preterm birth. Altogether, its constricting neck helps to hold the mucus plug in place, prevents cervical stretch, and redistributes the load, helping both the cervix and membranes remain intact. But since preterm birth is a multifactorial condition, and the current solutions are not, improvements need to be made. So, of course, we can look to nature. However, all mammals appear to experience preterm birth, so that might not be the route for ideas. Instead, we can draw inspiration from the natural system that we want to fix itself. And if we break down the three prongs of the solution I'm about to present to you, we can see that the cervical pessary can be considered inspired by the cervix, as it is meant to mimic the load-bearing and constricted nature of the healthy natural system. Combining progesterone and PRB inhibition helps to mimic the natural progression of the hormone's effects in healthy pregnancies, and releasing lactic acid is inspired by the normal vaginal microenvironment, helping to maintain the pH in the way that lactobacillus does, and promoting a transition to lactobacillus-produced lactic acid instead. Now, how do we adapt these three ideas into a fully integrated solution? Well, I propose the adaptation of the most commonly implemented Arabin geometry pessary to include two indentations for fitting drug-eluting rings. Intravaginal drug-eluting rings are commonplace for administering contraceptives and can be easily repurposed for preterm birth-specific active agents. I propose that the superior ring be impregnated with nanocarriers of progesterone and a PRB inhibitor that are constitutively released over the long-term timescale of pregnancy. This location will allow delivery with the ideal proximity to the cervix and uterus. The inferior ring interfaces with the vaginal microenvironment and thus can incorporate lactic acid release. And as I will discuss, there are techniques to do so in a pH-dependent manner. In that way, if the microbial colonization is predominantly lactobacillus, the pH will be maintained by the bacteria themselves rather than the device. And then there's just a general schematic here of how I envision this being used. So let's look a little closer at those rings. The superior ring would utilize an insoluble matrix design to incorporate a silicone elastomer with the active agents. Silicone is a highly biocompatible, elastic material that is already implemented in many intravaginal ring applications. The selection of nanoparticles rather than a traditional vaginally introduced progesterone drug formulation was chosen based on work done by a lab group out of Johns Hopkins who found that their nanocarrier solution of both progesterone and PRB inhibitors significantly increased the effectiveness of the drug delivery. These nanoparticles are muco-inert, which allows the agents that are typically poorly soluble within the vaginal mucus to be delivered more effectively. They are also the ideal size for passage through the vaginal epithelial cells. Intravaginal rings made through this insoluble matrix design are ideal for long-term release, with contraceptive ring insertion times ranging from 3 weeks to 12 months while maintaining doses of up to 10 milligrams daily. However, this design often results in a burst release upon initial insertion before leveling out to the intended dose. To address this in contraceptive rings, a group from Argentina developed a cellulose membrane coating that reduces the burst phenomena by adding an additional barrier for the initial concentration of drug embedded on the surface of the ring to diffuse through. They produced a mathematical model relating thickness of the membrane to the release rate, which I encourage you to look into if you're interested, but suffice it to say, this allows tunability of the kinetic properties. In particular, it modifies the following equation, which is more of a general look at insoluble matrix design release rates. The membrane helps to prevent that initial burst or rise of the square root function. The parameters of this equation, again, allows for more tunability of release rates and timeframes, as you can vary the drug load per unit volume, add surface modifications to the nanoparticles to alter the solubility with the polymer, and other parameters. With the optimal parameters, the ideal outcome would be a 3-month diffusion period suitable for third trimester intervention with a 4 to 8 milligram dose delivered daily, as that is the currently accepted dosage for vaginally administered progesterone in preterm birth applications. The inferior ring is a bit more complex and utilizes a different but also commonly employed intravaginal ring design, a core reservoir. Core reservoir rings, as the name implies, have a hollowed out portion where drugs are stored for release and a rate-controlling membrane of some sort. In this case, the rate-controlling membrane is a pH-sensitive window, as described by a multidisciplinary group from Canada and South Korea. The majority of the ring is composed of basic polyurethane, which is impenetrable by the nanocarrier formulation of the drug, with sections of pH-sensitive polyurethane that are crafted by an electrospinning process. If you're interested in the pH-sensitive fiber chemistry, definitely check out that paper, but the authors found that both polyurethane formulas that I propose using in this ring are biocompatible. The pH-sensitive release is mediated by 2 main factors, changes in porosity and changes in electrostatic interactions with anionic nanoparticle solutions. When the vagina is at a low pH from lactobacillus lactic acid production, the fiber porosity is very reduced, and the membrane thickness swells greatly. Together, this means more tortuosity of the pores and greater distance required for drug diffusion. Additionally, in a low pH setting, the anionic nanoparticles are electrostatically repelled by the fibers, creating a force that prevents migration out of the ring. In contrast, high pH environments increase the porosity, decrease the thickness, and neutralize the electrostatic force, allowing for a constitutive release of the particles. This was successfully used for nanoparticle dyes, but new nanocarrier formulations of similar dimensions and charges would need to be designed to deliver the lactic acid instead. The release kinetics of a typical core reservoir ring design are defined by this equation, where the length of the core and the dimensions of the core versus window can be used to tune the release kinetics. The variable for drug solubility within the polymer is a parameter that is under the control of the pH sensitivity and proceeds as described above. The ideal outcome would be lactic acid delivery to the vaginal mucosa only in high pH and therefore low lactobacillus environments that would pose risk of preterm associated infections. Putting all these pieces together, the final design implementation would look something like this upon insertion and would be ideal for third trimester use. At the expected delivery date or the induction of labor, the ring-laden pessary would be removed to allow normal vaginal birth to proceed. Overall, each of the components should work synergistically to manage some of the mechanical and chemical parameters contributing to preterm birth. Redistributing the load via the pessary will help to protect the membranes, constrict the cervical canal, and prevent stretch at the boundary between the uterus and cervix. The canal constriction should also support the blockage between the vagina and uterus maintained by the mucus plug. Administering lactic acid will maintain the pH at 4.5 by releasing only when the pH exceeds the typical value. The balance at 4.5 is ideal for the chemistry of the mucus barrier to remain intact. In addition, this low pH mimics the lactobacillus lactic acid release, thereby reducing unwanted microbial diversity that contributes to inflammation. By inhibiting other species, Lactobacillus has more space for colonization, as they can survive in the harsh environment. And the increase in those bacterial species imparts the effects seen in the healthy female reproductive tract of reducing cervical mottling and inducing anti-inflammatory cytokine production. The progesterone combined with anti-PRB helps mimic and restore the natural progression of receptor transition experienced in pregnancy, shifting the environment back to the anti-inflammatory state and reducing cervical mottling. Together, all of these effects address many of the multifactorial concerns for those at risk of preterm birth. However, this is, at the moment, probably a bit of a dream design. While the injection molding and electrospinning processes, as well as the basic elastomeric materials of silicone and polyurethane are cheap, easily manufacturable, and scalable, the drug and membrane production processes are probably not. However, there is hope as nanoparticle research is making rapid advancements that should help not only in creating new particles for new uses, but also in improving the capability to mass produce them cheaply. This will be especially important for addressing the need for preterm birth prevention in low-resource areas. However, some other strengths of the design are the modifiability of the rings, as they can be adjusted for patient-specific dosing, and the ease of insertion. This removes the need for surgical intervention and intramuscular drug injections that are being used currently, which will also make the technology more accessible. I also wanted to share with you all the sources that I used in creating this project in case you're interested in any aspects of the natural system or the potential solutions. I also want to highlight number 3, which I did not use for this presentation, but it is a really fascinating paper that describes a bio-inspired solution addressing specifically cervical insufficiency with a silk hydrogel injection. And my friend actually works in that lab now, so it's super cool. This topic was super fascinating to me. I am super happy I got to share it with you all, and I cannot wait to see your comments. I also wanted to mention that I did my last Chalk Talk on cervical remodeling, if you're interested in learning more about the mechanics of that tissue specifically. And then lastly, I just wanted to thank you all for a great semester, and I'm really, really excited to see what awesome ideas you all came up with for your final projects. Bye!